Good morning. My name is Tom Scott, and I direct the residency rotation in developmental and behavioral pediatrics here at the university. And I'm delighted to introduce our grand round speaker for today. Dr. Rob Garofalo joins us from Chicago, where he is Director of Adolescent Medicine and Professor of Pediatrics at Northwestern University, Feinberg School of Medicine, and of the Center for Gender, Sexuality, and HIV at the Stanley Menn Children's Research Institute. Rob is truly a pioneer in lesbian, gay, bisexual, and transgender health. As he started his career, he was instrumental in adding a sexual orientation question to the Massachusetts Youth Risk Behavior Survey and published his findings about adolescent risk in pediatrics. Over time, Dr. Garofalo's primary clinical and research activities have related to the care of marginalized youth populations, including HIV-positive and LGBT young people. His research group's work has been largely HIV prevention in nature and has mostly targeted young men who have sex with men and transgender individuals. Dr. Garofalo's current area of research and clinical interest involves working with young gender-variant children and families. Rob, welcome to the University of Minnesota, and we look forward to your presentation.
Thank you so much for having me here. This is like take two because I didn't make it here the first time because of snow. And I almost did make it here yesterday, but I managed to in the long run. It's really an honor to be here to talk about this topic. I think the last time I was here was 2012 when Eli Coleman, who directs the Center for Human Sexuality here, invited me to give a presentation. It was actually a Jocelyn Elders Endowed Chair lecture, which I was really honored to give around the Institute of Medicine findings. The Institute of Medicine back in 2011 published findings related to the LGBT communities, and he asked me to give that talk. And it's actually, if it weren't for Eli, I wouldn't be standing here today, because during that visit here to Minnesota, I had the good fortune to meet Colonel Jennifer Pritzker. I don't know if people know Jennifer, but Jennifer Pritzker is one of the, Pritzker Pavilion, Pritzker School of Medicine, of that Pritzker clan, and she's been a long-standing supporter of Eli's program here in Minnesota. And I got to meet Jennifer while I was giving that lecture and developed a relationship with her. And it was, I think, a year later when I went to Jennifer's foundation, the Tawani Foundation, and asked them to support starting a program for gender-nonconforming or transgender children in Chicago, being the first in sort of the region. And so it's with the good graces of Jennifer that we actually began to do this work. So I'm very grateful to Eli Coleman and the folks here in Minnesota for making that introduction, because I can remember going to my chairman at the time, and actually the CEO of the hospital, and saying, I want to start a program here for transgender children. And the response was, you want to do what? Like, how many kids could there be, like this? And I said, well, actually, I don't really know what the, what our volume will be, but I suspect it will be more than any of us think. And give the talk today, we'll talk about that a little bit. But again, it is with a tremendous amount of gratitude that I am doing this work today. And I'm grateful to be here. And certainly, I really started a talk with a thanks to Jennifer Pritzker and the Tawani Foundation for giving us a start to do this work. Oops. Okay. So I don't have any disclosures to make. And the treatment recommendations really are based upon best available evidence, which is very little. Okay. I'm not sure what I'm doing wrong. Hold on one second. Hold, please. Let me figure this out. Okay. So the objectives today, for the objectives for my talk, are to learn a little bit about the developmental trajectories of gender nonconformity or transgenderism, and I hate that term, but in children and adolescents, to learn a little bit about some of the approaches on the assessment and care for these children, and understand some basic concepts about medical treatment. So our program at Lurie Children's, the program of gender and sex development, is a combined program which is overseen by both myself and Dr. Earl Chang. So Earl Chang is a urologist who really oversees the sex development part of the clinic, which is really infants or children with disorders of sexual development. And I really oversee the gender aspect of the program, which is really for children and adolescents that are gender nonconforming or gender fluid or gender questioning. And although there is a small overlap in sort of populations here, they're very distinct populations. And I often tell what I think is a funny story, in that when our hospital conceptualized this larger program, they were insistent that these two programs share like a clinical space. And I was like, oh, I really think that's a bad idea. I mean, given my own experience, there's not a great deal of compassion between these two populations who see themselves as very different. And I said, all it's going to take is one clinic session where you're going to have a mother of an infant, of a child with a disorder of sexual differentiation, who's going to look cross-eyed at one of my inner city, transgender youth, and bedlam is going to occur. And I was incorrect in that it took less than 2 hours for like a shoe to go flying across like a waiting room. And so since that moment, we actually have separate clinics and separate parts of the hospital. So there's, I think from a hospital standpoint, there's a lot of reason to sort of combine these programs. I think institutionally, we get a lot of buy-in because we have surgery, believe it or not, like at the table as part of our program. But when it comes to the operations of the two aspects of the program, they really do operate pretty distinctly and separately. In fact, when I had to explain to Jennifer Pritzker what a disorder of sexual differentiation was, it was a challenge, because when she decided to fund our program, it was really focused on the sort of the gender aspect of the program. You really can't pick up a newspaper or watch TV or turn on or go to the movies without there being some component of gender nonconformity that you're seeing in the media, whether it's the Washington Post or the New York Times. If you haven't seen the PBS Frontline series, Growing Up Trans, which I'm not advocating that you watch because my team was in it, although we were. It's a really remarkable 90-minute, you can see it online still. It was nominated for an Emmy. The parents and the children in that series were really remarkable. The filmmakers were really quite exquisitely talented at getting these families to open up about their real lives and experiences. And I could stand up here for 3 days and not impart the wisdom of what it's like to be a gender nonconforming or transgender child as watching that 90-minute PBS special. I think these families and children really do sort of a remarkable job. I will also say that recently I got to go to Cannes, the Cannes Film Festival in France, because I had 20 lines in a movie, which premiered at the Cannes Film Festival. And the movie is called They, and it's a coming-of-age story of a transgender child where I got to play myself. So I was like not going to pass up the opportunity to go to Cannes. And I got my own IMDb page as a result of it. So I'm very excited that as a sidebar, I now have my own IMDb page because of issues related to transgender youth. But, and I think Caitlin Jenner, is the epitome of sort of how this field or this concept has really gotten a lot of exposure. And we could stand up here and argue about whether Caitlin Jenner has become a positive or a negative impact on this field or this community. And, I often say that what transgender young people need is transformational change in a broader sense within society. And I still think that Caitlin Jenner's coming out for a large extent was just a transformational moment for her, rather than being a real transformational moment of change for the community. But you can see that increasingly, I think there's just a lot of interest in gender nonconformity, particularly in this population. And it's really an area where I think medicine all of a sudden is intersecting with civil and human rights in a way that I've not seen since the early days of the HIV epidemic. So I don't want to date myself, but it is what, the early days of the HIV epidemic, medicine and civil rights really intersected in a way that was profoundly difficult, I think, for physicians and for medical centers. And all of a sudden, I find myself in a very similar position. I mean, not a week goes by that I'm not asked by the ACLU or by some court case in some aspect of the United States to comment on legislation related to bathroom use or locker room use. And I could spend quite literally my entire work week just writing amicus briefs or just committing to participating in legislation across the country that is really pitting these young children in ways against systems that really profoundly challenge the way we think about civil and human rights. So what do we know about gender nonconformity in young people? We know that increasing number of these kids are being referred to care, and I don't know if Eric and the folks here are seeing the same explosion that we're seeing in Chicago, but when we started our program in 2013, I should know this, but I think it's 2012, I think we had 12 kids that we took care of, and it was just me. We had no funding. Thanks to Jennifer Pritzker, again, we were able to form a very comprehensive model of care where by the time we started our program, we had endocrinology on board, we had 2 pediatricians, we had medical ethics, we had 2 full-time psychologists, we had a psychiatrist, we had a very comprehensive team. But I think last week we saw our over 650th patient. So we see about 20 new patients per month. We have a 5-month waiting list. I said to my chairman when we went to start this program, I said, if you start this program now in 2012, which was when we approached Jennifer Pritzker, and sometimes I talk out my ass, but this time I didn't. I said to him, if you start this program in 2012, you will forever be a leader in this field. But if you don't, 5 years from now, you're going to start one of these programs anyway because everybody will want one. And that has really proved to be the case. So in 2012, we were one of maybe a handful of programs that really existed in this area. But at last count, I believe there's over 50 programs that now exist in pediatric institutions from across this country. So you've really seen an explosion and a real desire to provide care for these children, mostly because these children and their families have demanded that care be provided to them. And so it's been a real example of where the populace or the kids themselves and their families have demanded better systems of care for themselves. We know that they're actually presenting for care at younger ages. We see kids as young as 3 or 4, to dispel any misconceptions. It doesn't mean we're giving like 3-year-old boys like a vagina. That's not the way gender programs work. In fact, none of the medical interventions that we'll talk about actually get instituted before pubertal age, but that's, I think, a general misconception. And we know that many young kids are now being referred to centers by primary care specialists. So I'll just very briefly sort of go over, I'm still struggling with this, okay, with the notion, that there's a difference between the term sex and gender. Sex, I really think, is a biological construct, which is an attribute that sort of characterizes sort of maleness or femaleness. It's generally determined by anatomy or chromosomes or hormones, whereas gender is much more of a social construct. It's about attitudes or feelings or behaviors. It's often cultural, that one associates with a person's biologic sex, and it can relate to expression or identity. It can vary by place or time. Think about how often, though, we in a medical context confuse the concepts of sex or gender. Sometimes I think when you're rounding on patients, oftentimes people will use terms like what is the patient's sex or gender, and we misuse those terms, I think, frequently. Inadvertently, I think we do it, not consciously, I should say, but even things like passports or institutions like homeless shelters often, I think, use terms like sex and gender, and they conflate the terms because they're not sure which they're actually referring to. So like, for instance, on your passport, it asks for, it has a field for sex, but it doesn't really have a field for gender, and yet the picture on your passport might really relate to your current gender, but that might not necessarily relate to your sex, which is often assigned to you sort of at birth upon anatomy. So you can see how the distinctions here can quickly become problematic if the two are not concordant. So if the sex that you're assigned at birth is not concordant with your current gender identity. So there's some shifting perspectives that I think are important here. I mean, it wasn't that long ago, like 2 years ago, where we were using terms like gender identity disorder, and that was in the DSM-4. The principal criteria were sort of persistent cross-gender identification, resulting in sort of clinically significant distress. We'll talk a little bit about that term, clinically significant distress, and how I think that has changed in many of the young people that we see. It's now being replaced with a more client-centered or patient-centered term like gender dysphoria. So gender identity disorder has really been replaced in the DSM-5 by the term gender dysphoria, which again, the principal criteria is again clinically significant distress resulting from the incongruence between one's assigned really sex at birth and one's asserted gender. The key concept, though, here, as the field is evolving, is that gender identity is not a pathologic condition. So someone who might have gender dysphoria or someone who has a gender identity that is discordant from the sex that they were assigned at birth does not imply a pathological condition. It's not an affectation. Someone who may be transgender or gender nonconforming, that is a very stable identity. Depending upon the time course. I mean, perhaps not in a prepubertal child, and we'll talk a little bit about that, but by the time one reaches adolescent age, someone's gender identity is a firmly established thing, not something that is an affectation or something that's going to pass. So when we talk about the this is the Dsm-5 criteria, I just want to focus on the bottom bullet. I'm not going to read these criteria, but it says the condition is associated with clinically significant distress or impairment in social, school, or other areas of function. I think for those of us that see many of these children, that impairment is really dependent upon the environment in which these children are raised. So I think many of the families, push us to, or challenge the systems in which they get care to think a bit more progressively about these terms and about these diagnoses. So many of the young people I see, particularly who are allowed to socially transition at young ages, and we'll talk a little bit about social transition in a bit, don't necessarily display any significant impairment or necessarily any distress in sort of social, school, or any other areas of functioning. I think many of these families present with children that are doing extremely well if allowed to just be themselves. And I think that's sort of the key when we're dealing with these families and these children. Really what a gender program is doing, particularly with kids that are prepubertal in age, is just providing families and children support like we would do with any other child or adolescent. When I talk about what our gender program does for children, I talk about it within the same sort of constructs that I would talk about providing any other care for any pediatric population. I mean, what we're really doing is providing these children with an environment in which they can grow up healthy and happy. And if that just means allowing them to sort of be their authentic selves, as they are as children, then that's, I think, what our job as pediatricians is to do. Okay. So I think a lot of people get hung up on what's the prevalence of, gender dysphoria? What's the prevalence of being transgender, in the United States or sort of in the world? And there have been a few studies. Here's an example of two of them, but they're kind of shitty. So I don't really spend a lot of time on them because these studies are imperfect. And I guess I would argue, does it really matter what the prevalence is in order to provide, care to this population of young people. I just told you that, we see over 600 patients in the past 5 years. We have a waiting list of over 5 months for these services. So, I think oftentimes as clinicians and as scientists, we want to sort of define sort of populations precisely in order to then to know how many people out there might need our services. I just think that this is always going to be a bit of an imperfect science because, this isn't like counting sort of beans in a jar that are really easy to sort of count. Now, the alternative to that is that I think in some ways, in order to count, you need to be counted. So there was a push to include questions about gender identity and sort of sex in all sort of federal health surveys. And there's been a rollback of sort of that and since the Trump administration has come into office. But I think it is important to sort of include those questions on all federal health surveys because there may be health disparities that affect these populations that we're entirely unaware of. And only by asking those questions are we really going to really begin to know whether people that identify as gender nonconforming or transgender might be at risk of certain social or other health conditions, and we can compare them to other populations. So on one hand, I think we overemphasize identifying the actual prevalence of disorders, and I put disorders in quotes because I don't believe this is a disorder. But on the other hand, I think in order to really count in this country, you do sort of need to be counted. And so I do advocate the continued inclusion of those sort of questions in sort of federal health surveys moving forward. Moving on to sort of gender development. I mean, we know that most children begin to develop develop the ability to label gender by about the age of 2 or 3. And between 2 or 4, most children recognize gender differences and use gendered pronouns. And by age 5 or 6, most children can begin to declare their own sort of gender identity as sort of male or female. And for most children, this identity is consistent with their birth-assigned sex and will remain sort of consistent across the lifespan. We know that many children will experiment with gender expression in toys and gender expression in roles, will do some cross-gender play and might exhibit cross-gender dressing. And exploring gender in this way is a very sort of normal part of sort of childhood development. But some children may exhibit what we consider sort of persistent, insistent, and some people would say consistent, non-conforming behaviors or expression. And is it possible to sort of distinguish sort of what's a behavior or an expression versus what may be an issue related to identity? So, when we think about gender nonconformity in children, when we think about what the trajectory of these children could be over the course of their career, what does a gender nonconforming child look like when they become an adolescent? We know that they could grow up to be a transgender adolescent or someone who's genderqueer or a sexual minority youth, but they could also grow up to just be a plain old simple heterosexual young person or an adult. So we don't really have a good understanding of yet of an ability to predict which children are going to end up in sort of which box. And therein lies, I think, the problem when you start thinking about medical paradigms to start treating these children. So any person or any clinician that's going to stand up here and tell you that they can predict with 100% certainty which children are going to grow up to be sort of transgender, I'd tell you that they're lying. Because I have been fooled. I mean, I've been doing this work for a long time, and there have been kids that I am convinced I know are going to, persist in being transgender, and then I'm wrong. And so I think that's why when we start talking about some of the medical interventions, we emphasize that these medical interventions are really not initiated until these young people sort of start to go through puberty. So again, can we predict the persistence of gender dysphoria. Again, I think it's impossible to always predict. There was one sort of significant study out of the Netherlands, which looked at a clinic population, and it did suggest that the likelihood of a transgender identity persisting can be predicted by, and this is not rocket science here, a high intensity of gender dysphoria as a child, or the tendency for a child to assert cognitively versus affectively, like I am a boy, versus statements like I feel like I'm a boy. So, making a cognitive statement as a young child versus sort of an affective one. But again, I think the challenge here is that our job as clinicians isn't to make that prediction. I think oftentimes that's what families are looking for us to do, but that's not really our job as clinicians. Our job is to really provide these children and these families with just a supportive environment so that they can figure out who they are, who their authentic selves are moving forward. Our job is to really, I think sometimes parents will ask me to make a decision about how they should they socially transition their child. And I think I really have to take a step back to be like, my job's really to tell you what we know and what we don't know, with often what we don't know being a lot more than what we do know. But then the decisions are really for these families to make. Our job as clinicians is just to help guide them into making a decision that's within sort of their best interest. Okay, so when we start talking about the care of these children, when we're talking about the prepubertal child, there's really sort of three behavioral health approaches. One is a corrective approach. One is sort of a wait-and-see approach, which I think is almost impossible to do in a world that is increasingly gendered. And then one is sort of an affirming approach. I'm going to briefly sort of go through these. The corrective approach really is hopefully an approach that increasingly will become antiquated. But it is an approach that sort of aligns a young person's gender identity and expression with their natal sex. The basic tenets are to prevent the development of transgenderism, if that's a term, and to prevent psychosocial adversity. It identifies gender identity or gender dysphoria as a pathology, and that it implies, much like we used to imply for sexual orientation, that gender identity is somewhat malleable through behavioral techniques. The strategies are really to discourage gender nonconformity, to encourage gender normative play, and it only allows social or medical transition for children who are 16 or above. When I say the word social transition, it's social transitioning is allowing a young child to live as their authentic selves with like dress or pronoun use or even names in school or at home. And sometimes families can do that just within their home. Sometimes they'll do that in a larger environment. But social transitioning implies allowing a family to raise their child in a gender that's not consistent with the sex that they were assigned at birth. But it's not a permanent intervention, right? It's a sort of social intervention. The corrective approach has really, the main proponent of this was a guy named Ken Zucker out of Toronto, who's a very controversial person in this field. He's also a very well-known researcher in this field. And, he's done a fair amount of research that suggests that if you apply a sort of a corrective approach, that fewer of these children will end up growing up as transgender than if you do not apply a corrective approach. And that makes sense to me, right? So if you apply tacit pressure for a child to conform to the sex that they were assigned at birth, regardless of what their authentic selves are, it makes sense to me that fewer of those children might actually grow up to sort of be transgender than if that pressure was not applied to them as children. But I would say that, and I do a fair amount of research, that outcome measure is the wrong outcome measure, right? Like, who cares, really? We're not counting beans in a jar. It doesn't really matter to me whether children end up being transgender versus less being transgender. What matters to me is whether these children end up being happy as their authentic selves as adults. And so Well, I think Dr. Zucker's research was a nice start to the field. It's a good indication of how this is an imperfect science, right? And so we're asking the wrong question. Really, what we should now do is go back, and people are beginning to do this, to the children that Dr. Zucker studied, and we should ask them, like, about how happy they are as their authentic selves as sort of adults, because that's really the ultimate outcome measure here. And so I think the corrective approach is something that, again, is very controversial sort of in this field, and is not the way I think that most progressive centers that provide care to these children and families are operating. The wait-and-see approach really is very difficult, I think. It implies that gender variations are not disorders, that gender nonconformity or transgender identity cannot be determined early on, but the strategy is to neither encourage nor discourage gender-related behavior. It tries to stay as sort of neutral as possible. Where that's extremely difficult is just that, again, we just live in a very gendered society. I mean, you can't, it would be very difficult, I think, to maintain neutrality in its purest sense in a world where you're bombarded by sort of gendered decisions almost 24/7. So I think it's a very difficult, I think a lot of families find this approach appealing, but I think it's very difficult to sort of implement when it comes right down to it. So an affirming approach, which is really an approach to sort of help a child or a family decipher sort of subjective gender experiences and sort of differentiate those that might have sort of some persistent identity from those that just might be exploring some gender nonconforming expression. Again, the tenets are that these variations are not disorders, that gender can be fluid and not always binary, that some youth may be able to be distinguished from non-transgender youth prior to puberty, but not with any, not with 100% degree of certainty. But the strategies are what I discussed before, to really sort of assist youth and families in learning about and engaging about gender transitioning as both, and learning about the social and medical interventions and allowing them to make decisions that are in sort of their best interest. An affirming approach does not mean encouraging or pushing a family towards gender transition. It just means sort of affirming that child in that moment and knowing that at least in a prepubertal child that any of the interventions such as social transitioning are not permanent, that these are reversible sort of interventions and approaches. Why do we believe in an affirming approach? I mean, we just know that children who are not supported or children who are rejected early in childhood, are at increased risk of a range of adverse medical outcomes, including depressive symptoms and self-harm. We know that family acceptance in particular from the work of Caitlin Ryan is really instrumental in promoting sort of positive self-esteem and positive mental health. And so we think, at least, that early treatment can lead to sort of better physical and psychosocial outcomes. But do we know that? Not really, because right now the outcome literature on these young children is scarce. There's almost been no outcome data presented on these children from the United States. There is I'm blanking on her first name, Olson. It's not Joe Olson, but Christina Olson, there we go, from Washington, that is doing a good deal of sort of research in this area using an online sample. But the outcome research is really scarce. And so this is an area where I think a great deal of work sort of will need to be done in order to sort of improve the body of evidence-based medicine that we base our practice on. When I approach our families, we have a 4-page consent form, when we approach them around either pubertal blockers or cross-gender hormones. And I often say to family, and those consent forms are fraught with like coulds, might statements, possibly. There's not a lot of definitive statements on those consent forms. And I often say that before I retire, I want those consent forms to be 1 page instead of 4 pages, or to not exist, actually, ideally, But right now, there just isn't a lot of evidence-based medicine for which to support the interventions that we're offering these families. Okay, so I'm just going to go through a couple of vignettes. So the first vignette is a prepubertal child. So these are cases from our actual practice. Andrew reports from his earliest years that he prefers dresses and playing with makeup and dolls. He asks his parents to buy him feminine clothing and a wig on a number of occasions. He tells his parents, "I am a girl." Again, that's a cognitive statement versus an affective statement. He tells his mother, "I can't wait to get to heaven to finally be a girl." We didn't see that as, sort of a self-harm statement, more that he viewed heaven as sort of an idealized world where he could be who he or she wanted to be. They visited their pediatrician, who told them this was just a phase. A year ago, the parents allowed him to begin to wear dresses and a skirt inside the home. Again, an element of social transition here. They note that he's much happier during those times, and the mom tearfully expresses he's so insistent. It's beginning to feel oppressive, not allowing him to be who he is. And they notice that he's becoming more withdrawn and starting to avoid school. So this is a pretty classic presentation of a prepubertal child. Again, but the presentations vary widely, often depending upon environment. Without a pressure to conform, I think, again, children might not be dysphoric in any way. I think that's really important because I think, again, the diagnostic criteria really speak to dysfunction as being a critical element to the diagnosis. You're going to see, as time goes by, more patient-centric diagnostic options, because I think both families and clinicians are beginning to balk at selecting diagnostic criteria that do not quite fit the children that we're seeing. Anyway, I think many of these children might become angry or upset or withdrawn when parents or others attempt to redirect their behavior, particularly if redirected to sort of conform to the sex that they were assigned at birth. So we've been talking a little bit about social transitioning. Again, it's the way that a person presents themselves to the world in terms of physical appearance or names or pronouns. It has real implications for how children use things such as bathrooms or dorms or locker rooms. And again, we talked about some of these civil rights cases. Again, I think at last count, there were more than 20 of them across the United States, which were cropping up. I've been asked at least to write amicus briefs for over 10 of them in the past 6 months, which is dizzying in terms of just how, again, there's this intersection between medicine and civil rights, which is not unique, but certainly not commonplace. And again, I think social transitioning remains somewhat controversial, in part because, again, there are very few outcome studies related to whether social transitioning has positive or negative outcomes for these children in the long run. And some of the work that has been done have been done in strictly European contexts. And I would argue that in this particular area, context is really important, and these studies need to be done in the United States. I remember when I first started to do this work, I presented with Anne-Lou de Vries, who's an endocrinologist from the Netherlands team, and she presented this case of this young trans woman that was able to transition and was living her life perfectly happy and fully engaged in society in the Netherlands. And as I was watching the video of this young person that she was showing, I thought, wow, this just doesn't seem like the story of like young transgender women that I see in the inner city in Chicago, right? And so, I mean, context, I think, becomes really important. And so in the Netherlands is a far different society in the way that it thinks about gender and sexuality than, let's say, the inner city of Chicago or the south side of Chicago maybe. So social transitioning within a context in the Netherlands might look very different in terms of its outcomes than allowing someone to socially transition, again, in the south side of Chicago. And so the outcome studies that we do, I think, are going to need to be very culturally tailored and sort of culturally specific. The second vignette, Jack is a 9.5-year-old natal female affirmed male. He reports a preference for stereotypically masculine clothing. and play since the earliest years. He reports knowing that he really is a boy since the age of 5. And he remembers insisting on typical male clothing and cutting his hair short. He did socially transition at the age of 5. Parents report some resentment and aggression towards a younger brother. I think that's really important because when we do this work, I think we often think of the unit of intervention when we provide medical care of being the child. Here I often think of the unit of intervention as the family, because I think so much of this is family-centric. And although we do focus on the child, a lot of the work that we do is on the entire family or on other systems. When we got our money from the Tawani Foundation, the one area that we didn't think we'd be doing a lot of was school interventions, right? So we actually have someone that has done more than 70 school trainings in the past year. And if we didn't have that person to do those trainings, a lot of the care of these children would be suboptimal, because where do they spend so much of their time during the day but in schools? Okay, so Jack also expressed concern about anxiety. He seemed withdrawn, and he has a strong concern that he's going to grow breasts or develop pubic hair. I don't want this to happen because I am a boy, and boys don't have breasts or don't have those. And on exam, he's an early Tanner 2 with early breast development. So I think when you care for these children, obviously to have a good understanding of puberty is really important. So, the development of secondary sex characteristics becomes an area where dysphoria can, for the first time, really become present. So for even kids that have been allowed to socially transition or are doing well, dysphoria can become present when they begin to fear or develop these secondary sex characteristics, which are considered to be inauthentic or not part of their authentic selves. So it's important to know, what are the early signs of puberty? In a natal female, that's breast development. In a natal male, it would be an increase in testicular volume. Things like menarche is a late pubertal finding, or growth spurts, again, are late pubertal findings. So again, for these young people, they really want their puberty to be caught early, because the interventions like pubertal blockers, which we'll talk about, can really sort of suppress the development of these unwanted, really, secondary sex characteristics. So I shouldn't even say peripubertal, it should be early pubertal children. For gender nonconforming adolescents, these physical changes can really be unbearable. And again, that's when gender dysphoria will really intensify or emerge. Again, the early interventions with GnRH analogs or pubertal blockers can alleviate, we think, psychological harm. Again, not well proven within the medical literature. But we do know that these agonists will effectively suppress the production of sex hormones at the pituitary level, and increasingly are being used in centers across the United States. This is just a schematic of the agonists. I'm going to go by that. Again, I think of pubertal blockers as, again, buying a bit of time. These are reversible interventions. You can't block puberty forever. Someone can't be Peter Pan for the rest of their lives. They eventually, someone is going to have to go through puberty. So it is a completely reversible intervention. It does potentially allow time for exploration of gender while sort of distress, the development of sex characteristics is being alleviated. It does help prevent the physical of an undesired puberty. Hopefully it can prevent the need for sort of future medical interventions or surgeries. We do consider these safe. Again, GnRH agonists have been used in other conditions like precocious puberty for many years and are considered safe, but we do not have a good understanding of the long-term outcomes within this particular context. So the long-term follow-up studies within this context are somewhat meager. Some of the potential risks, really, that are not fully studied relate to sort of bone density, height, and then the impact on sort of cognitive or sort of brain development. I think these are 3 areas where, for those of you in the room that are doing this work, if you're looking for areas to do some independent research, these would be 3 areas that I think are important for us to begin to study. I will say that 2 years ago, the NIH funded a network of sorts. So our site, Boston Children's, Los Angeles Children's Hospital and UCSF were fortunate to obtain the first NIH grant to look at long-term medical outcomes of medical interventions on these children and adolescents. So we are just beginning to collect our first data on our clients and the study participants, but hopefully this will be a study that will be ongoing for 15 to 20 years. You never know with the NIH, but hopefully. There are practice guidelines to help guide us, although they're constantly being revised. And so this is the Endocrine Society guidelines. They were last published in 2009. They should be revised again and at any moment now. I've been saying that for almost a year, but they should be released again shortly. Right now, they recommend, at least in an early pubertal child, that adolescents who fulfill certain eligibility criteria undergo treatment to suppress pubertal development. But again, you don't initiate these treatments before the first signs of puberty and no earlier than Tanner stages 2 or 3. Again, that's because we think that whether a patient persists in a gender-nonconforming identity or desists when they're a prepubertal child, there's a tremendous amount of fluctuation there. But once a child reaches pubertal age, the thought is that someone's gender identity is a bit more firmly established. So that's why we don't initiate these until sort of pubertal age. The last vignette is, again, we'll call this patient Jack, is a 15-year-old natal female, affirmed male. Again, we can sort of read through this here, but he asks for boys' clothes only. He wants a haircut that's like a boy. He told his mother that God made a mistake, that he really is a boy. He tried to be feminine to fit in, but he felt miserable. But in the 5th grade, puberty started, and he became increasingly distressed. Again, I think that's very common, again, with the development of these secondary sex characteristics that are undesired. He disclosed to his parents in 7th grade, and his mom told him that it would go away. And they didn't discuss it again until this past year when the mom noticed that he had increasingly discomfort with his body. So this is these are patients that we still see in our practice, but hopefully over time we'll see fewer of these patients as I think primary care providers begin to be more comfortable in identifying children that hopefully can be referred to centers that do this work. This is a child that obviously has progressed fairly far into puberty and is presenting somewhat later in his or her course. But this is someone that you would consider sort of the initiation of cross-gender or cross-sex hormones. Again, they're indicated for adolescents with consistent, persistent, or insistent gender identity issues or concerns. The goals here are to reduce sort of an endogenous or undesired sex hormone and replace those endogenous hormone levels with those of one's asserted gender, thereby inducing really what is considered a secondary sex characteristics of one's affirmed or asserted gender. The Endocrine Society, again, has guidelines here, although I think they're not guidelines that typically most places that do this work progressively adhere to. In particular, they indicate that someone should not start these hormones any earlier than the age of 16. I think, again, most of this work is related to the Dutch protocol, the work that has been done in the Netherlands, where, again, I think the onset of puberty is much later than it is in the United States. So, like, for instance, the Dutch protocol, they don't initiate pubertal blockers before the age of 12, or the traditional Dutch. If I waited until the age of 12 to initiate pubertal blockers, particularly for many of the natal females, I mean, the horse would be out of the barn by that point. There would be no point in doing this work. I mean, we're initiating pubertal blockers at the age of 9, 10, or 11. And so the difficult questions that I think exist in this field are how long do you keep those pubertal blockers without sort of initiating cross-gender hormones? So would you really block someone's puberty at 9 and then wait to initiate cross-gender hormones until the age of 16? What implications would that have on their cognitive development or their linear growth or their bone density? What implications would that have on their social ability within schools, right? Again, think about a South Side Chicago young person who might be blocked in their pubertal development at the age of 9, would you really keep them blocked until the age of 16 before you would allow them to go through a puberty? I think most places, at least in the US, have not adhered to these particular principles. So we generally will initiate potentially cross-gender hormones at younger ages, as young as 14, even 13 in some rare cases. But again, I think many of us that do this work have a much more sort of patient-centric or family-centric approach and are not necessarily just follow sort of guidelines that are really not necessarily empirically driven. So most of these guidelines really haven't been developed with a strong evidence base, particularly from outcomes research in the US. I would argue that the outcomes research that these are based on are really meager even from European studies. So I think, again, a lot of the care that we're doing is really targeted toward the populations that we are currently seeing. So at Lurie, again, we have an individualized management approach. We do initiate cross-gender hormones prior to the age of 16 because we believe that not only could the initiation of those hormones have good psychosocial benefit, but it also could really be beneficial to the patient in terms of other areas of both physical and social development. Okay, we do believe at Lurie that the treatment of these children does require psychosocial support. So that does put us at odds with the way that this field has moved, at least in adult circles, and I don't have enough time to sort of get into those distinctions, but at least in the adult field, we've really moved to a model of sort of an informed consent model, which is really, can people sort of consent for themselves about the risks and benefits, and if they can consent, should they be able to move forward without the need for explicit mental health or psychological support? I'm not going to argue the risks, the benefits, or the pitfalls of that particular approach. At Lurie, we do believe that these children require mental health or psychosocial support as part of our process. So we do require a letter of readiness from a mental health provider to move forward with either cross-gender hormones or pubertal blockers. Now, that said, we live in a somewhat idealized world because we have 2 full-time psychologists that are paid for by philanthropy that can provide care for free if need be. Sometimes it's hard to find mental health providers in the community that are equipped to do this evaluation and it's not an evaluation of someone's gender. I want to be really careful here. So I hate when families come in and they're like, hey, Dr. Garofalo, can you evaluate my kid's gender? I'm like, sure, ask them. There is no evaluation of someone's gender unless, it's just a young person is going to tell you themselves. We do also require parental consent. This becomes complicated. Again, I don't have a lot of time to go into this, but if parents are married, then we only require one parent's signature. If they're divorced, we require both parents' signatures, unless we actually review the divorce decree, which becomes difficult. Again, we talked a little bit about the letter of readiness, which I just believe is really important when doing this work with adolescents. When someone is going through a transition, I think that's not the time to initiate care with a mental health provider should they become distressed. Ideally, we would want, it's really about, the informed consent model is really a model about access. And I think insisting on mental health care is really a model about quality. So I agree that we should be improving access, but I also really think the transgender community deserves us to start thinking more broadly about quality of care. And I really do believe that the highest quality of care is for these young people to be engaged with a mental health provider. Okay, so I only have 5 minutes. I'm not going to go through these because you can read them. These are just some of the effects of testosterone and estrogen. Okay, I'm going to close with some of the barriers to care. So we know that the cost of these medications can be exorbitant. And so I actually was someone who's very optimistic and believed that care would continue to become increasingly available. Well, in the past year or so, I've seen a rollback of my own optimism and a rollback as I think insurance companies have become a bit more emboldened to sort of deny care in ways that has been really disturbing to me. So our program, we have a full-time nurse that does nothing more than fight insurance denials. I mean, that's crazy. So in our program, at least in our second year of operation, we had an 80% insurance denial rate. But with our full-time nurse, we had an 80% success rate of overcoming that denial. But that's a labor-intensive process. But the medications are particularly expensive, and there still continue to be a tremendous amount of insurance exclusions. There still are a tremendous lack of medical providers, and in particular a lack of mental health clinicians that lack the experience to work with these children. And a lot of times you have to overcome these families' past negative experiences with healthcare in a way that's pretty substantial. So a brief word about the clinical environment. I think you have to be sensitive to really all aspects of an infirm gender. You know, we will start like, you know, how do you like to be called? We wear buttons on our shirts that say like preferred pronoun, so that the families know that that the type of program that we are and that we plan to be affirming of their child. We start meetings, it sounds ridiculous, but things like, hi, I'm Rob, I prefer he, him pronouns. Like, what gender pronouns do you use? I mean, that may sound silly, but for children and families that are gender nonconforming, those types of introductions go a long way in making them feel comfortable. Gender neutral bathrooms, that became a big battle for me in our hospital, but even single stall bathrooms that have gender neutral signs are very welcoming for families and are really important in helping families feel comfortable in sort of your clinical environment. When to refer, I think, again, if medical providers are uncomfortable, if you've identified youth or family members that are struggling with gender nonconformity, if you have families or young people that are seeking more education about gender identity, or if you've identified youth that are expressing interest in sort of gender-specific medical interventions, or if families or kids have psychosocial concerns that may be related to gender. You know, what do youth want their doctors to know? This was a quote from a young person in our gender clinic. I don't consider myself to be any kind of sick because I'm transgender, and only wish to be treated with the same casual, natural respect you give any person. Basically, I dislike it as a transgender person when my gender makes people uncomfortable or awkward. I'm just another person. And I think this quote really sort of sums it up. I mean, most of these young kids and their family, or the young people and their families, just want to get care like any other adolescent. They're not, you know, they may need some specialized care related to being gender nonconforming or transgender, but ultimately they don't want to be defined by their gender nonconformity. And so that's, I think, the challenge, I think, to many of us providing the care is to treat these young people with the same respect and dignity that we would sort of any other sort of adolescent patient, and not having them feel so othered as they sort of interact with sort of the medical environment. So in conclusion, I think, and you know, this was a whirlwind of a talk, but this is a really sort of challenging and novel field. Again, you know, there's so much work that still needs to be done. Most of the work that we're doing is really based upon a lack of evidence, and is really based on sort of best practices. Know it, but there's a tremendous amount of need for continued work in growing a body of sort of evidence-based medicine here. In terms of the development of a gender and sex development program, I do think individuals require a plan that's formed around their goals and that really take into context both the family and the environment. Again, our jobs as clinicians is to explain to families what we know and what we don't know about treatment options, and then it really allows them to make the decisions. I think it's really also important that we let families know that withholding treatment is not a neutral decision. So oftentimes I think families will think like, well, I don't know if I'm comfortable signing that consent form, because what if I made a mistake? And it's really important to sort of let families know that by deciding not to move forward with treatment is as active a decision as by moving forward and signing the consent form and moving forward with treatment. as I've mentioned a number of times, I think research in a broadly, I think, in a number of areas is sorely needed. And I'm really excited to be part of this NIH grant, and hopefully this will be just the first of many NIH grants to come for institutions across the United States. I know that what I sort of brought to the table, I think, I was the newest clinician to this particular cohort of sites, but I knew how to write an NIH grant. So I think that was helpful in getting this one secured, but we've also been working with other sites across the country to help them sort of get started doing some of their own outcomes research in this area. So again, I think when we think of the goals of a treatment team, it should focus really on creating a safe space for children and adolescents to explore their gender identity, and then again to help these families navigate sort of these medical and social challenges. So with that, I'll stop, and I thank you for having me here, and I'm available for questions if you have them. Yeah.
So what if a child is not yet an adult, but they are old enough to make these decisions, but their parents withhold treatment?
Yeah, there have been some pretty high-profile cases. I think the highest profile case was a case of Layla Alcorn, who was an Ohio teenager who had written in her social media blogs for 6 months that, were she not allowed to move forward, she would harm herself. Ultimately, she stepped in front of a tractor trailer and killed herself and I'm a strong believer that access to care saves lives for these children. And so we've never come across a case that we couldn't work with families to move them forward in some way. I mean, the options are really, if you really think that access to care is something that's critically important, you could go the route of having a child go through legal emancipation. I often don't recommend that because it's such a traumatic event to legally emancipate from parents that would use that as an absolute last result. We have used guardian ad litems as well to sort of intervene and sort of help make decisions for sort of older adolescents. So there's a number of approaches you can take, but I am a strong believer that access to care really does save these young people's lives, and a refusal to move forward with care. And I understand it. I mean, if you watch the PBS special Frontline, there's a father of one of my patients who's pretty ambivalent about whether he should move forward and allow his child to get care. And after the show aired, he called me up that night and was like, "Oh my God, I'm afraid to go to work because I looked like such an asshole on that show." And I was like, "I don't think you looked like an asshole. I think you looked like someone that just really didn't know what to do." And I think that's more the case that we deal with, which is families that just don't know what's the right thing to do. They're afraid that there isn't a strong evidence base, that they're afraid that they're making the wrong mistake. And so there are, I think, a lot of options as you ramp up interventions, but the most severe would be legal emancipation.
And what do you think about that case in Canada where the mother doesn't want to assign a gender? Do you think that's healthy?
I mean, I don't necessarily think it's unhealthy. I just think it's very difficult to do. No, I don't think that's unhealthy. Because the child, I mean, it's like the new paradigms for care for intersex or for children of disorders of sexual differentiation, where we don't declare a gender until the child declares one for themselves, right? So if they're born with ambiguous genitalia, the new paradigm is to wait until a gender is declared by the child before a surgical intervention is.
We're almost out of time, but we have time for one more question.
Thank you very much. So I really appreciated you talking about the focus on an outcome and an outcome that is really patient-centered. And I think that has it's an approach that a lot of us in other fields can learn from. Can you talk a little bit about how you're kind of conceptualizing this outcome of your care and how you're measuring it and how you discuss it with families?
Yeah. Well, I mean, I think the way we're conceptualizing it is from everything from like safety, so that's probably the first step, is to, are these interventions safe, to then sort of, are they efficacious? And by efficacious, it can mean everything from quality of life to what are the sort of physical developments, so we are measuring things like estrogen dosing and, development of breast tissue and things like that, to, sort of all other sort of outcome measures that could relate to mostly quality of life. The NIH study that we have, which is really the first of its kind, is really an observational trial. So it was one of the tricks, because we couldn't get these 4 sites to agree on one, we couldn't get 4 sites to agree on one paradigm of care, right? Because there's no one way to do this. So it's one of the challenges, I think, that these 4 sites are going to have to publish this data, because I think we're each doing something a little bit differently, and that's going to make it a challenge. But most of our outcomes are mostly mental health in nature, even though it's not framed as a mental health grant. Really, most of the outcomes right now are quality of life, depression, anxiety, resolution of things like PTSD, mostly mental health outcomes.
Thank you very much.
You're welcome.
Really appreciate you being. I just wanted to quickly remind faculty there's a faculty meeting at 4:30 today. We'll start here at 4:30. So thank you very much, Dr. Garofalo. Appreciate it.